Good afternoon. My name is Aaron Levo. I'm the Vice President of Communications and Public Affairs at Hamilton Health Sciences. Pleased to moderate today's town hall. As always, today's April the 22nd, and we have another packed agenda about what's happening in our pandemic response and across the organization. We'll have a chance to answer questions at the end of the content presentations. As always, you can type questions as we go in the Q&A function. Please use the Q&A function to type questions. Our panelists may answer your questions as we go, and you'll see those responses stack up in the answered tab under the Q&A function. And then we'll also have celebrations at the end. Our President and CEO, Rob McIsaac, was required at a regional planning meeting today. So fortunately, we have Sharon Pearson, our EVP Clinical Operations and Chief Operating Officer with us today to kick things off and to give a bit of an operational update. So Sharon, over to you.
Great. Thank you very much, Aaron. And good morning, everyone. Thanks for taking the time and tuning in today, particularly when we know we're in some of our most challenging times through this pandemic that we have experienced to date. In terms of where we're at with our COVID activity, last Friday, the COVID-19 Science Advisory Table provided an update to the province with projections, and the data pointed to the rising number of cases and the sharp increase in the number of patients or individuals that will require critical care. And we've all seen this playing out on the media, the news, the social media, etc. And while we know that the projections will be influenced by the vaccines and the supply and the uptake and other measures, such as the current lockdown, the Ontario Science Table stressed that for the next few weeks, as they put it, the die is cast. And the picture is not looking optimistic for the hospitals. We know activity in the hospitals tends to lag behind some of the projections. I'm hopeful today that Dominic and his update might be able to shine a little light and show us some optimism in what we have in the weeks ahead. From across our hospitals in our regions, we will continue to work together to ensure that we provide access for our local programs and our regional programs across the hospitals in Ontario West and the province, and also continue the work to ensure that not one hospital in the region in Hamilton is unduly burdened by the volumes created by COVID. And also looking to expand our acute care and our critical care, our ICU capacity wherever we can across our centers. And lastly, to align our people to ensure we have staff available to care for the sickest patients through this pandemic. And we'll hear more about some of the strategies today to assist us with that. We continue to hear stories through the news about the pressures our partners are experiencing in the GTA and across other parts of the region, and patients are being transferred through directives and measures to the east, to the south, and to the north. And certainly we are participating in Hamilton and in our region with the census balancing that needs to occur and having daily, if not more frequent meetings to manage and monitor the patient flow and patient care activities that are happening. Unfortunately, we may not be through the worst of it, and we may need to make further adjustments along with other hospitals to our activities in order to free up the essential capacity and the staff that we need in the weeks ahead. We do use our ethical framework at HHS to ensure we have fairness across all of our programs and to support our decision-making, but fully appreciate that these are very difficult decisions and they do affect the lives. They affect the lives of our patients, their families, our staff, and our physicians. So we take all of these decisions with the utmost seriousness. Today on our agenda, we will get an update again from Bruce Squires on the vaccination and the distribution. We continue to hear wonderful, very positive feedback around our Wellington Street Clinic and the staff. So I do encourage all of you, if you've not had your vaccine, please sign up for that. The details are on the website. But we do know that even after vaccination, as Rob characterizes COVID often as a tricky virus, we cannot let our guard down. So I do ask that we all remain vigilant and diligent in following our infection control practices and guidelines, both when we're here at work and when we're out living our other lives. So I'm really hopeful, as we all are, I know, that this is our final big push against the pandemic. It's affected all of us. It's affected all of our clinical staff and our support staff, but it's also affected our volunteer staff. And this week, I'd like to acknowledge that it's National Volunteer Week, and I want to give a special shout out to our volunteers and the Volunteer Association, because they too, during the pandemic, have experienced significant change and continued to support and adapt us. And we thank you very much for all that you provide to our patients and our teams. So once again, thanks to everyone listening today, everyone who may listen later, for your ongoing support and for going above and beyond to support HHS through the pandemic. I'll move on to today's agenda. We will get an update today, an operational update. I'll have a few minutes. We'll also get a vaccine update. We'll hear our regular update from Dominic. We have Kristen Kroll today to talk to us a bit about nursing and deployment. And we'll also hear from Michael Stacey today around the emergency standards of care and triage. With respect to more details around the operational update, as I commented, we do have a need to create more critical care capacity, and the province is looking to create up to 1,000 new critical care beds, which is a staggering number of critical care beds. We did get a provincial directive the day before last regarding all non-urgent and non-urgent surgeries and procedures should be ramped down, and that has and is happening across our hospitals, across our HNHB, the West and the province. And this is needed not only to accommodate the COVID population, but also the non-COVID population as well, because we continue to have volumes of patients arrive with unscheduled medicine needs as well. If we could go on to the next slide. In terms of the balancing strategy, just to update you on numbers, to date, there's been 164 patients transferred into the HNHB, and 48 of those have come to HHS. We are in a sort of a mode now where we get a day before communication that identifies how many patients that we will be receiving and from which sending hospital. And really our goal is to avoid situations that we do not have to enact the emergency standards of care and triage. So it is so critical that we create this capacity and do this census balancing across all of the hospitals in the province. Certainly, we continue to work on the ramp down. At this point, we'll await messages for further ramp down of services. In creating the capacity right now from a level 3, which is our highest level of acuity beds, we have added an additional 38 beds by the end of this week. So that takes us from 88 beds to 126 level 3 critical care beds. And also through a series of strategies, we have deployed 200 staff to support these beds. So thank you to everyone who's participated, all of those staff that have been deployed that are helping in these efforts. If we go to the next slide, today, sort of the pulse check on today is we have 102 positive COVID patients, 39 of those are in the ICU, and there are a number of recovering patients as well. I will just comment on the occupancy because we talk about the occupancy pressures and some have asked that they don't seem to change or appear low. We have to remember the impact of the outbreaks, of which we have 4 right now. They can make our occupancy appear lower because we do have blocked beds because of the inability to admit. We also add new beds into the denominator for our occupancy as we open those beds. So that's why you see some variation in the occupancy numbers each week. It also includes occupancy from all our sites, including Children's and St. Peter's and the satellite. Our HHS adult occupancy is over 90%, and that continues to be between 90 and 105%. And right now we have 107 staff and physicians self-isolating as a result of COVID or COVID contacts. If we go to the next slide, in terms of what else we're doing to create capacity, both from a bed perspective and from a staff perspective, there is a significant press upon long-term care to provide expedited access to long-term care beds. So we're working with our home and community partners to do that. We are maximizing our satellite health facility. We have additional 2 beds at the satellite health facility that we will be working on opening into the future. As of Monday, we do have a temporary closure of our urgent care center, as well as a full redirect of obstetrics and an OR closure at West Lincoln Hospital. There have been further adjustments to our ambulatory service reductions. We continue to support a very robust virtual model with 40 to 50% of the visits occurring virtually. And we have ramped down our regional rehab center to 50% capacity as well. And then lastly, you'll see a most recent photo from Kelly Campbell of our mobile health unit. And as she will point out, that's not snow on the roofs, that's our tents. So the work to erect the tent is complete, but there's much work still to do on the interior and setting up for full occupancy that we're targeting for the end of May. So that completes my operational update. And if we could go on to the next slide there. I'll hand it over to Michael Stacey to speak to the emergency standard of care and triage.
Yeah, thanks very much, Sharon. So what I'm going to be talking about is this emergency standard of care and the critical care triage protocol. And there's been some communication go out this week, primarily to the physician group, but also broadly to the group at the hospital around what this is. And just firstly to say, as you heard Sharon talk about, there have been really concerted efforts to open up additional critical care capacity. And the reason for that is to ensure that we can find places for patients who need critical care treatment. And the idea of it is to try and avoid having to go to this emergency standard of care. But essentially, this is really a two-step process, if you like. And the first step relates to the emergency standard of care, which really are guidelines for us on how we triage patients needing to go into ICU. So this really is something that can only be called by the Ontario Critical Care COVID-19 Command Centre, and it would be done on a province-wide assessment of our critical care capacity. So in other words, when we're approaching that capacity, they would call this. And the reason to call this is to ensure that we have some beds in ICU for those patients most in need of critical care, and also the ones that have the most likelihood of surviving that. So a part of this process is to do for the physicians to complete what's called a short-term mortality risk assessment on each adult patient who needs critical care. And depending on the level of scarcity of beds, we would be in different levels of triage. And essentially, the way this works is those with the highest mortality risk would be the ones who may not be allocated an ICU bed in the first instance. If we get deeper into this with fewer beds, then it would be ones with even lower mortality risks that might also not be able to get into the ICU. This will be supported regionally by a regional triage team who helps to determine whether the patients based on this STMR would be suitable for critical care with the capacity we have left, and then would work out an allocation of where that patient might go across the region. So potentially these patients could go into any critical care bed within the region. The second step of this really is what's called the critical care triage protocol. And this really requires a cabinet executive order to allow this to happen. And what this really means is that we would be withdrawing care from patients in critical care without their consent or the consent of their substitute decision maker. So, as you can imagine, this, is not something that we would likely do. We would need that executive order to change the consent legislation temporarily in the province to protect the clinical staff who are enacting this. But having to get to that level, as one can imagine, would be very traumatic for families, very traumatic for staff who are having to make those decisions and to deliver those messages to the families. So clearly avoiding this is absolutely what we're attempting to do. And a big part of that is opening up the additional critical care beds, the ones that Sharon's alluded to, and also having a plan for where our next group of critical care beds might be. There is a physician education and training underway with this. There's been a simulation done last week on doing the short-term mortality risk assessment and understanding the process of triage. So lots of work to get prepared. We desperately hope we'll not have to use this, but if we do, we need to have a way of managing this. And as you can imagine, this is a little bit like, being in at a military field hospital in a war zone, where basically you have to prioritize, who goes first to get the treatment that is not available to everyone. Being in a civilized third world, urban population, we hope we never have to make those decisions. So I will pause there and pass on to the next speaker.
Thanks very much, Dr. Stacey. So up next, we have our epidemiology update, as is our standard practice, from Dr. Dominic Mertz, who's our Medical Director of Infection Prevention and Control. Dominic, where do we sit in terms of the spread of the pandemic this week?
Yeah, thanks, Aaron. After weeks where I only was showing red arrows, as in the last week here, this week looks slightly better. If you can move to the next slide. We have multiple provinces that may be turning the corner at this point of time. You see BC, you see Saskatchewan, you see Quebec, and you see Ontario as well, hovering at an RT of around 1, which would mean that at least we see a tendency for a plateau or even cases starting to come down. So that's good news. Whether this was going to be the new trend or whether it's just one peaklet and it will continue to rise afterwards, that's something the next days will show, but at least it looks better than what I would have shown you last week. With all of this being said, we did see an increase until very recently in terms of our case numbers. Next slide. So this is again, I use this slide again with the federal modeling from mid-February and how we compared again at the national level. It seems like we may have passed our peak, but again, let's wait and see. But it remains between the blue and gray line, as we always said. Next slide. Next slide. From a provincial perspective, this is where we are currently sitting in terms of weekly number of cases. We can expect, if the current trend continues, that this week will be lower than the last week was, probably at around 200 or 30,000 cases a week. Next slide. However, and we don't expect an improvement here within the next week or two, number of hospital admissions continue to increase. The red bars showing you number of hospital admissions, the darker red bars number of ICU admissions, and the very black smaller ones are your intubated patients who every week achieve a new all-time high. Next slide. Now, how do we compare to the modeling? That was the modeling from April 1st by the science table, which I said ended up to be too optimistic, actually. And we were, our red line here that I added was above their most likely scenario, what they assumed to happen. So that was bad news. But the question always was, as I mentioned last week, whether the consequences of Easter were an anomaly due to social gatherings during Easter, or whether that's a sign of an ongoing trend. If the trend now changes, it would suggest that, again, it was an Easter anomaly as we've seen over Christmas. And now we start to see the true trajectory after that. And at this point, some good news with a curve that's been flattened. Next slide. This is how we compare to the modeling from last week. So since that modeling came out, we have a more or less stable line sitting at around 4,000 to 4,300 cases, rather than 5,000 plus that had been predicted. So again, fingers crossed that this is the new trend and not just an anomaly for a few days and then going back up again. Next slide. this is the ICU modeling. And as I kept saying, this is pretty much spot on and had been spot on. We are at 800 today, pretty much as predicted already back in April 1st. On the next slide, you see the more recent modeling from April 16th. And again, spot on. Yes, we are sitting at 800 now, and we don't expect that this is going to get any better over the next week or two, even if number of cases are flattening now because of the delays until we see that impact on healthcare, as Sharon already mentioned. Next slide. Now the Hamilton view here, today they reported, I believe, another 140 cases. So again, it looks like, yes, we may be heading into the right direction, but it's too early to call. But when you're looking at both of those lines, it looks like we may have reached the peak and are coming down. But mind you, we saw the same around Easter, but back then we were very cautious and saying, well, it just might be Easter and people not getting tested anymore. I'm a little bit more optimistic this time around that we are actually heading into a better direction at this point. Next slide. In terms of hospital strain, as you're probably well aware, we continue to see increase in cases on the wards, in ICU and intubated, far higher than what we've ever seen. And again, we continue to increase from week to week. The same picture basically as we saw on the provincial level. Next slide. The usual questions about VOCs. So I would follow here the dotted line because we don't do as much confirmed cases anymore, but based on the cases that have been tested for VOCs, you see that we are sitting at now in the 90% range within the province. Hamilton's been reported at 65%, but that report doesn't consider that not all of the positive cases have been necessarily tested for VOC. So that's probably an underestimate at this point. And on the next slide, you see the actual numbers of the 3 VOCs that we are dealing with at the provincial level, where you still see the vast majority being B117. When we are looking at the Hamilton picture that's on the next slide, it's also first and foremost B117 with more than 1,000 cases, 1 B1351 so far, and 1 P1. But we seem to see more of those mutations that would be indicating that it's one of those other variant of concern. So either the South African B1351 or the Brazilian P1 variant of concern. So they are certainly here, and it's not only those 4 cases or 3 cases that we've reported in Hamilton so far. I think that was my last slide, and back to you, Aaron.
Thanks very much, Dr. Mertz. Next up, I believe we have Bruce Squires, our Vice President of Women's and Children's Health, who will be giving us an update on our vaccine distribution effort in the Hamilton region and province. Bruce, over to you.
Thanks very much, Aaron, and good morning, folks. So the update on the numbers, as you can see, we're in the over 4 million doses in Ontario, as much as 136,000 per day. I think that was a record, and a reminder that distribution is really happening with the Pfizer and Moderna vaccines, primarily through large-scale vaccination clinics and through what we call mobile pop-up clinics operated by public health across the province, and then as well the AstraZeneca vaccine, which is primarily being distributed through pharmacies and through some primary care practices. In Hamilton, you can see the numbers there, including the HHS fixed clinic. We are starting to approach 30% of our over 16 population having received at least a first dose of a vaccine. So slowly but surely, we're making progress in protecting the population. Again, the biggest limitation remains supply, both supply coming into Canada, supply then being allocated to Ontario, and then being distributed across the province. In April, we moved into what's been described as phase 2 of the vaccination program. A reminder, important reminder, that phase 1 populations continue to be eligible, including healthcare workers. So as Sharon highlighted, really encouraging all of our teams, if you haven't yet registered for the vaccine, please do so. If you have questions about the vaccine, there are a number of links on the hub that can help you in answering those questions. And we can also arrange consultation. Phase 2 expanded to continue primarily the progress through age categories with the main vaccines of Pfizer and Moderna, and we're now where 60 plus is eligible across the province. I mentioned AstraZeneca, and just in the last few days, the eligible population for AstraZeneca has been reduced to 40. So now 40 plus is eligible, and again, a number of pharmacies and other mechanisms, including in Hamilton, are available for access for that vaccine. The individuals with health conditions category for vaccination is, of course, of particular interest to those of us at HHS as healthcare providers. And so the province has opened up the provincial booking tools, which is both a phone line and an online mechanism, to the highest risk category, plus one essential caregiver. And I'll speak to that in a moment. And again, really important to mitigating, looking to dampen the length and the extent of the third wave and any possible fourth wave, is the focus of the province on high-risk congregate living settings, excuse me, and hotspots, both of which are shown to be driving the third wave. And I'd include in that large essential workplaces. So that really is becoming a target of the provincial supply, and allocations are being adjusted to reflect the understood benefit of focusing on high-risk congregate settings, essential workplaces, and hotspots. Let's go to the next slide, please. And we'll go into that high-risk health conditions, so the health conditions category, a little bit more. Reminder that the highest risk is been defined with really these key areas. And so at HHS and across, working jointly with St. Joe's and with the city of Hamilton, we're really focusing on ensuring that that patients in these categories are aware that they are eligible for vaccination and through registration via both a call-in line with the province or the provincial booking system. Again, we're really looking to ensure that's coordinated both for adult and pediatric patients, because recognize for pediatric patients, there are exceptions that allow vaccination down to the age of 12, but most importantly, their caregiver is eligible for vaccination. It's been determined that this really is best done through large-scale vaccination clinics. So we're not moving to be vaccinating these patients within our hospital walls, but rather than encouraging them to book through the provincial tool to get the quickest available vaccine through a large-scale clinic, including the HHS clinic. If we can move to the next slide. So as I said, that really talks about highest risk is available across the province. It should be noted that some individual areas of the province, because they have a different booking tool, may have decided to also provide eligibility for the high risk health condition, which is a much larger group. In both the highest risk and the high risk health conditions, there is a portion that relates to patients with cancer. And so our cancer programs, both for JCC and for MCH, are reaching out directly to those patient populations to provide guidance with respect to vaccination as it relates both to their existing treatment and as it relates to those situations where an adjustment to the timing of the second dose has been permitted by the province. In other words, to allow for the first dose to be given according to the original product monograph. So in many ways, the responsibilities are the same as it relates to HHS. We're looking to communicate out to those groups so they're aware that that when the time comes for highest, and in some places it's already there, but for the province it's not yet, the time comes for them to be eligible for vaccine, that they can register, and also to facilitate correct scheduling for that limited group within the transplant and within the hematology and oncology populations who are eligible for an accelerated first dose. Next slide, please. This really says a little bit more about those exceptions. Patients with malignant blood cancers and tumors who receive immunocompromising therapy and transplant recipients are really the core groups for which the accelerated dosing interval is permitted. And so in those cases, a letter is being generated from our clinics, from our specialists, so that we can confirm that eligibility. So really what this really will show, and we'll go to the last slide, is that we have specific processes in place for our pediatric and our adult cancer patients to allow, for those who require it, facilitated booking. But for this group and for all other health conditions, the vaccination itself at this point is being provided through large-scale vaccination clinics. And that really is the most effective way to get vaccines out to the largest number as quickly as possible. So I'm going to stop there, Aaron, and I'm going to turn it over to our next speaker. Well, I'll turn it back to you to turn it over to our next.
I'll do that for you, Bruce. Don't take my role. Next up, I'd like to invite Kirsten Kroll, our Vice President of Quality and Performance and our Chief Nursing Executive. Kirsten's going to give an update on some nursing standards related to the redeployment underway right now. So Kirsten, over to you.
Yeah, thanks, Aaron, and hi, everybody. Yeah, so this is following, of course, with all of the statements earlier on around how HHS is being responsive to the province and the higher acuity and demands for critical care patients who may be coming to us and perhaps in our own community. Of course, it is creating quite a bit of reassignment for individuals to try and meet these additional beds that we're putting into the system. And for sure, we've got a lot of reactions to that. But at the same time, I am so amazed with how people are stepping up. I do, though, want to talk about what might be going through nurses' minds and also other health professionals that are working alongside in our different team environments. The College of Nurses just issued last evening some statements to really recognize the great uncertainty and the stress that's going on in the province as people are going through quite a bit of massive reassignment. It's not only here, it's right across the province. So I just wanted to highlight these, and these statements are really important as they think about, you know, the role and the dynamic that we're in. So the standards of care are always considered in context. So this pandemic matters in the context of how the college and how all of us think about the care requests and provision of care that we're providing. Recognizing that this is a dynamic and evolving situation, and recognizing also that resources will likely become more scarce and absent in the system. The pandemic requires continual adaptation and adjustment in the nursing practice, and that nurses are always doing their best in every situation. And the College of Nurses would use all of this information in considering the circumstances that nurses are working within. So if there are complaints that are coming in from the public or whatever sources that might be coming to the college, and also mandatory reports that might be having to be submitted, the college is saying they are going to use that lens to appraise and recognize that we are in a very different time than what we would normally be. Next slide. So just to touch upon, this very unprecedented time, we've never been in a circumstance like this. So again, the degree of reassignment that is going on is quite phenomenal. Key things to think about in this approach. First of all, for people who are getting reassigned, and again, primarily nurses at this point, but other health professionals certainly are getting some of that messaging now too. So nobody's untouched from the point of view of the different disciplines, but really important that people, as they get to new areas, discuss the competencies that they have and understand what is expected of them, the responsibilities that they would carry. So dialogue is extremely important. Ensuring that you have the knowledge, skill, and judgment and the appropriate authority to provide the care that is expected. So again, we are not asking people to step out of their scope that they are not capable and competent to perform in. That assuring patient safety is always essential in this, and working with your colleagues. But having that reflective insight into, where are you confident and where you have that capability and what is outside your scope. The college's three-factor framework certainly has been in the profession for quite some time. Very important tool though for people to think about as decisions are being made. So for the nurses, do I have the knowledge and skills that I need to do the tasks, or to ensure that I'm not creating more risk, I'm preventing harm? Is this within my scope? Do I have the responsibilities and understand the accountabilities that I have in promoting patient safety? The patient aspects, really important in that assessment of, the patient's condition, always critical. Do you have the right skills for the patient's needs? How stable or unpredictable is this patient matters? How complex is the care? And again, how do people on the team maybe need to adjust what is expected in the assignment or the responsibilities of the day because of the changing demands of patients? And then the environment is the third key other factor to consider. What is the team dynamic like? Are they have they got specific ways that they collectively look at assuring safety? What resources are available for my use? Access to equipment, access to order sets, medical directives, and so on that may apply to me. What other policies and procedures on the unit are important for me? So that three-factor framework always is alive and well in each of us in the way that we're working. Whether you're a care provider, administrator, educator, or even a researcher, that three-factor framework applies to everybody in this environment. Perform activities that you're competent to do. Again, why that dialogue and that reflection is really important. But also related to that is seeking out the learning. Our educators and other advanced practice nurses and so on, even our seasoned nurses, all sorts of people are stepping up to help with real-time education, assessment of individuals who are coming into reassignments to really try and match, okay, how can we help build that confidence and ability to do the work, but also recognizing the limitations of somebody's scope. So there's a lot of resources that people can pull on, and we're trying to make that available certainly 7 days a week. And also seek advice and collaborate with the healthcare team to uphold that patient safety. So again, it's about recognizing that you're new to a team, different dynamic, get to know that rhythm and how people work. The next slide is really about individuals who are hosting, I'll say, or receiving individuals to their new teams, and how can you help? And I must say, even in these early days of these reassignments that are happening, people are stepping up big time. So thank you for that. But always supporting new colleagues and having the empathy that this is a substantive change for individuals. There's lots of different emotions that are out there. But generally, I would say the generosity that I'm seeing and the graciousness of people is second to none. this organization always knows how to step up when things get really tough. But there are going to be individuals for sure where they have good days, bad days, and we just need to be able to wrap ourselves around individuals, be in tune with what's happening, and support them. That means getting to know each other around the knowledge and skills that they have and the levels of competencies and how to adjust what's happening on the unit. Using that 3-factor framework for decision making. Looking at the team's situational awareness. So again, with all this disruption, for sure, we know that risks will grow in the organization. More demands are coming in, disruption to team members and so on. While we're trying to do everything we can to mitigate this, we do need people to make sure that they are congregating and talking about, what may be of concern about a particular patient picture that day. Highly encourage areas to think about doing more huddles. So maybe thinking about, how do we do a touch point with our team every shift instead of, just our CQI huddle with the safety huddle daily. How can that be ramped up so that people get that situational awareness? What is happening around us? Are there concerns? Let's make sure people have an active voice and contribute to improvements and discussions about either just-in-time improvements or something that might need a little bit more reflection and thinking. Can't underestimate communication is fundamentally important for our success in all of this. It's not going to be perfect. We're going to learn, we're going to grow. We've never been through something of this magnitude before. But again, it's how do we stay present with people, communicating, and really trying to find mechanisms that keep us glued together in this difficult time. And I am very confident that HHS will do a phenomenal job in this process. So thank you for that. I will turn it back over to Aaron. Thank you.
Thanks very much, Kirsten, and to all the panelists. Okay, we do have an opportunity now. I know our panelists, I have to give an early shout out to everyone for the work that they've been doing in the background, answering as many questions as possible. You'll note that if the question was answered throughout the course of our presentation, there's an answered tab within the Q&A function, and you can see the responses to those questions there. In addition, you can continue to post questions using the Q&A function, and we have a bit of a list there. And you can also raise your hand in the participants section, and we'll call on you to ask your question live should you wish to do so. So first, I know Bruce, you and I were chatting a bit in the background. You've taken a look at the vaccination related questions. Maybe you've aggregated some of them and can give us a response to some of those questions. So why don't we start there?
Yeah, thanks very much, Aaron. I'll certainly do my best. And in other sessions, I've really started by highlighting that that vaccination continues to be very heavily directed by the provincial government. So much of what happens is really determined at that level. There is some flexibility, some limited flexibility for local public health units to make adjustments, but for the most part, there isn't. And so that really is a core piece of a number of the answers. So also, there are questions around really essential workers, both early childhood educators and the notion of essential worker blitzes. So the province has only opened up the eligibility to special education teachers across the board for vaccination, and so that exists. The only other mechanism in place right now to target essential workers is through, we'll call it the hotspot strategy, that does allow in those high-risk neighborhoods or high-risk locations a public health unit to set up a mobile clinic, which could include going into a large workplace. A good example would be, of course, a factory, but it would also include for migrant farm workers. So a large farm. And so in Hamilton, the focus on those blitzes is underway at the planning stages. And I expect we'll roll out with additional mobile pop-up clinics in the next couple of weeks. Question around family members of healthcare workers as being prioritized for vaccination. At this point, that hasn't been something approved at the provincial level. Again, the focus has been, as I've described, on those areas that are perceived to be driving the spread of COVID with the higher incidence of outbreaks and of course of infection. Questions around accelerating the second dose for healthcare workers, particularly those going into COVID units, etc. And that is something that I think the health sector has certainly raised consistently with the provincial government. At this point, the direction has been very, very clear and firm that we're not in the position to accelerate those second doses for any other reason than the health conditions that I identified earlier, and very targeted our Indigenous populations, both living on reserve and in adult and in congregate settings. The questions around whether patients over 60 continue to get vaccinated, absolutely. And as that relates to our inpatients at the hospital, we do have a process set up for a frequent blitz through our inpatient settings to vaccinate those who are eligible. Questions around choice of vaccine, there really is not. And although there's been a couple of instances where a single clinic has had multiple vaccines available, product vaccines in the same day, for the most part, that is not the case. Of course, for public knowledge, the AstraZeneca is being distributed through primary care and through pharmacy. So that's really the only way to get to that. And questions around source of vaccine, just an opportunity again to really promote the resources available on our hub, but also on the Hamilton Public Health website, with really a multitude of different media and valid sources for all the questions you might have about vaccination. I think there were a few clinical questions, and Dr. Mertz has really answered those around vaccine efficacy and questions around variants of concern, I think, Aaron. So back over to you.
Yeah, thanks very much, Bruce. Well done. That was a lot packed into one response. Appreciate that. I do note that we have one participant with their hand up, Paula Belk. Paula, just in case you've done that in error, which has happened in the past, I'll ask another question. And then if you do have a live question, I'll come back to you very much next. I see she's abandoned that question. See, this is always, that's what happens. I get excited, think someone's going to ask live, and they don't. But anyways, would encourage everyone to try if you'd like. See a question here about protecting hospital resources for Hamilton patients. Maybe Sharon, you can comment a bit on that. I know there's lots of work happening regionally, provincially about balancing what resources are available. What's happening in that regard?
Yeah, thanks, Aaron. And this really is about the conversations that happen daily around what access we still require for our urgent care and our regional programs. And that's the whole objective of the regional conversation and the conversation with the province to say what we can and what we cannot do. And at what point we start to impact our regional programs. It's very important for us that we maintain that urgent, unscheduled access. So lots of planning around that to ensure we maintain that capacity. I see another question or a couple there, Aaron, around capacity that I can take on.
Sure.
What is our capacity as it relates to our typical bed numbers prior to opening so many extra beds in the last 2 weeks? Just for context, we have about 575 medical surgical beds between the Juravinski and the general site when you exclude the rehab beds. And really what we're asked to do by the province since the beginning of wave 1 is always ensure that 15% of that capacity can be made available for COVID patients. So that is always part of our objective in our planning, and it's embedded into our planning right now. Of the 100 and some beds that we know we always need to keep protected, we have about 60 of those beds full from a ward perspective. From a critical care perspective, we've committed to our 38 beds for COVID patients. Today we have 41 in the 38 beds, but we do have non-COVID capacity available. And then, Aaron, I'll just keep going. There's a question around creating the 1,000 beds. How will we do this when we've already doubled up rooms and the semi-private rooms at the JH. The planning does continue to create critical care capacity. We have doubled up the rooms at the JH. We have not taken that step at the general site. We are looking at all possibilities. That includes our procedural care areas, like the heart investigation unit, which we're doing now because of the ramp down in that service. We'd be looking at same-day surgery areas, recovery room areas, and other physical space that can be transitioned into critical care capacity.
Thanks very much, Sharon. I see the next question is actually about our urgent care capacity, rationale for closing the urgent care. Would this not just simply divert people to the emergency department? How is that balance panning out right now?
Right, so quite a thoughtful conversation needed to make the decision to temporarily close the urgent care center. Right now, our visits are down over 32%, and we've sustained that reduction for quite a period of time now at the urgent care center. So that leaves a range of between 48 to the high 60s in terms of visits per day. So really, we are thinking that volume can be accommodated through physician offices, through medical clinics, and yes, perhaps through our ED departments. What this does do is frees up that critical staff that have those essential skills that we need for ICU. That was our rationale with the UCC. And to date, in looking at the numbers this week, we have not seen an increase in our ED volumes.
I see. Tough decisions, but tough situation. So thanks very much for that response. Sorry, I just lost my window there. Question about, is information being collected on COVID-19 symptoms received after the vaccine? I think, Dr. Mertz, we've talked about this in the past. It's information that we'd certainly like to collect, but I'm not sure, is anything specific being done right now?
It was about vaccine data of our employees.
I think just generally speaking of those any that would have become symptomatic after being vaccinated, or at least receiving the first dose.
I mean, we don't do that as a hospital, but there's many researchers doing exactly that. Public health is able to link the positive test results with the vaccine status. So there's a lot going on in that field, and I think as a single hospital, we don't necessarily contribute to that. One of the other questions that came up was, do we see infections in already vaccinated? Yes, of course we do. We never said it's 100% protecting, but it's close to 100% protective from severe infection and from death. And I think these are the outcomes that matter most. Will there be one or the other case that will be fully vaccinated and may have a very severe outcome? Yes, that's likely going to happen as well, but we can reduce that risk by far more than 90%.
I just point out too, to those asking questions about the efficacy of the vaccines, the different science that's available now about vaccines. We have posted a resource available on the Hub. It has been pasted into the answered section in response to one of the questions. So you can certainly access that anytime to try and see if a specific question you have is answered in that material. Next question up is about redeployment, specifically those who are part-time becoming reanointed full-time. Is perhaps maybe Leslie Gillies, you could give us some sense of how that particular transition was discussed by the redeployment task force.
Yeah, thank you, Aaron. Certainly, we are supporting sort of all of the processes, working with the staff member, collective unions, leaders that they report to, and the receiving management as well. Trying to, you can imagine sort of the timelines that we're trying to work within. So some general principles certainly to follow, but also going back and following at an individual level to support people as best as possible. In this transition. As you can imagine, we're trying to, and hopefully achieving opening up all the required beds by the end of the week, but we're at different levels of deployment depending on sort of where people are coming from. So working as collaboratively as possible to maximize our coverage, but also trying to support the staff in this transition and recognizing that this is not an easy process.
Awesome. Thank you for the response. I just want to be, there was a question in the queue about people eating in specific areas at our McMaster site. I might have cleared that out accidentally as I was trying to get my window up. So just bringing it back, they've noted that there wasn't a response. And you're right, we didn't actually specifically address that question. So just bringing it forward, I don't know, maybe Kelly Campbell or maybe one of our IPAC specialists might want to comment on what has been done in our sites to try and create safe spaces for eating, any additional work underway in relation to corridors, et cetera.
Yeah, so I can start, and Bruce may want to add in because it's specific to the McMaster site. I know that we're challenged with places that we can put tables and still have that physical distancing. I hear the concern. Putting plexiglass on a table, though, creates a whole nother safety hazard in terms of tipping and the weight. So we have to be careful with that. Again, just hearing about it today, so don't know if there is a fix for the McMaster site, but certainly between Bruce and I, we can take that back and take a look.
Great. Thanks. Okay, so great. We'll take a hard look at that, and that'll move forward. So wonderful. Thanks for raising that issue to whomever did. Okay, going back to our questions here. One about, will healthcare workers who contract COVID be exempt from ICU triage? I'm not sure that really nests within the content that Dr. Stacey presented earlier, but maybe if we got to a point, there would be, like, how would that fit within the triage protocol and the things that you presented on earlier, Dr. Stacey?
Yes, and maybe just to comment, I think the principles behind the triage protocol is that it's meant to be equitable, and you know, everybody's being considered on their merits based on that STMR. So there are no exceptions to this, if you like. You know, everybody is considered equal under this, and it's based on their likelihood of mortality on that STMR assessment that's done.
Gotcha. Okay, I'm conscious of time. I know there's questions here about viral spread, vaccination intervals, et cetera. We will do our best to get responses to those questions. But I also want to leave a brief moment for celebrations, as is our normal tradition at these town halls. So important that we take a moment to recognize the good and the great that's occurring in our organization and elsewhere. So if you'd like to give a shout out, you can type it into the chat function and Sharon and I will read it out. Or you might raise your hand and provide that shout out live. I know, Kelly Campbell, I think you had one in particular we talked about before we began.
Yeah, thanks, Aaron. So in the midst of everything going on, just to remind everyone that not only is it Earth Week, but today is Earth Day. And so, I mean, essentially every day is Earth Day, and we should be thinking about our conservation measures. But just wanted to highlight a few things that are going on corporately. There'll be an Earth Week Lunch and Learn on the 27th of April. You can RSVP for that by sending an email to waste@hhsc.ca. There's lots of materials on the HHS Hub homepage, and the dispatch from yesterday had a link to an environmental survey that you can take, and there'll be a random draw for a $50 prize for that survey. As well, just to let everyone know that despite the pandemic, we have continued to make great strides in our environmental efforts. In 2020 alone, we diverted 41.3% of our waste from landfill. We sent 170 metric tons of food waste through the green bin recycling program. We had 586 metric tons less waste in 2019, which is amazing when you think about all the extra PPE we're using. And as you know, we did introduce a PPE recycling program last year. So overall, in terms of our CO2 emissions as well, we've achieved about a 17% reduction. So we're making strides. We continue to push forward, but just to remind everyone to celebrate today and take part in the activities going on.
Thanks very much, Kelly. I note we have two Leslie G's with their hands up. I don't know which one to choose. Why don't we go to Leslie Gauthier? I think you were first in the queue.
Yeah, thanks, Aaron. Sorry, Les, I won. Just want to acknowledge and let everybody know that as of today, the HRLMP lab is actually starting to do the testing for variants of concern. We're one of 4 provincial labs that have been selected to do this work. And so really, really good news for our community and faster turnaround time on the variants. And in particular, Mark is acknowledging the work of Candy Rutherford, who is one of the technical specialists in virology. And she's actually taken on and done a great amount of preparatory work that we can provide this service. So congratulations to the lab and a special thank you to Candy.
Wonderful. Leslie Gillies, next up.
You got me, Les. A sincere thank you to the all of those staff that have been involved with the pandemic deployment, the staff that are transferring, the staff that are receiving, to both the wards in the ICU, physicians, nurses, interprofessional health, clerks, and the list goes on. Huge amount of work done by the CSO staffing group, and couldn't have done it without you. Thank you to the leaders as well who are supporting their teams.
Nice.
Aaron, I wonder if I might read out the message from Morgan in the chat because it's so important. We acknowledge our volunteers. So Morgan has written, despite navigating challenging times, Volunteer Resources would like to acknowledge National Volunteer Week and honor the invaluable contributions of our volunteers and their services to our patients, families, and fellow volunteers. Our volunteers have continued to support HHS in many facets, whether through virtual opportunities that have been made available or by way of general support. Volunteer Resources wish to thank them and our wonderful program and partners that provide exceptional experience and supports to the volunteers of HHS. So great message, Morgan, and so important that we acknowledge our group of volunteers.
Wonderful. Thanks, Sharon. I see Susan Cucciarelli, you had kind of asked for a prompt here for a celebration of sorts.
Hi, yes, certainly just to thank everybody for all of the tremendous work that they're doing, and just to remember next week, so next Wednesday, April the 28th, is the National Day of Mourning. And for those who are not aware, this is to honor those who have lost their lives or suffered injury or illness on the job. Certainly as we continue to battle the COVID pandemic, just want to recognize all of the frontline workers, both here at HHS and regionally and globally, who have lost their lives in the course of protecting and caring for others. And we'll be flying the flags at half-mast next Wednesday. And you can also look for online recognition celebrations and tributes that will be occurring.
Thanks very much, Susan.
I wonder, Aaron, if we could squeeze a couple more in because there's some really important ones in that.
Yeah, let's do it.
Panelists today, but a message from Kirsten wanted to recognize Therapeutic Rec Day that occurred on Monday. They make an important impact on people, keeping people engaged with body, mind, and spirit, and so important on people's quality of life. And I would echo that. We don't shine a light on our therapeutic recs enough, I don't think, and they do a fabulous job. So congratulations to that group. And also a personal call out to Tina Folds, retiring from the clinic, Technology Access Clinic this month after 43 years at HHS. So congratulations to Tina.
Yeah, great. Thanks. Congratulations, Tina. One from Joanne here. A shout out to the 4 West staff handling the COVID outbreak. Great teamwork. A reminder to everybody from Victoria Brzezowski about the RSVPing for the Lunch and Learn that's highlighted in our chat forum. One from Rebecca Fleck, a huge thank you to the regional rehab program and teams for their leadership and their hard work to decant the regional rehabilitation center to 50% in such short order. We also see here a happy birthday to Nate Vandendoel and recognizing him for his teamwork, supporting the team in redeployment. So happy 30th birthday, Nate. What else do we have here, Sharon? We missed any?
Yeah, we have missed some. Congratulations to Carissa Corden and her team for all the great work bringing nursing externs as the work to the work we do to recruit nurses at HHS. From Dale Bialis, congratulations to all the staff, physicians, and teams that are creating unconventional spaces in the HIU and ICU, thinking outside the box and continuing to provide excellent care during outbreaks. We have strong teams and want to recognize and congratulate all staff. Thank you, Dale, for that. Agree 100%.
One here from Michelle Leaflor. Shout out to the biomed teams for the work they're doing to support the ICU. Another celebrating Christine Chaston, clinical manager of the Master Children's Hospital Emergency Department as she moves into a new role as clinical manager at HHS. Christine's made a huge impact on her colleagues and the experience of patients and families. Another, oh, you go.
I just see one, Aaron from Mary Dempsey. Congratulations to Kelly O'Halloran and Patty Ann Allen and all the staff for the successful opening of the 3rd floor of the Satellite Health Facility. It's a beautiful facility fulfilling the needs of ALC patients as they await their discharge plan. Thanks for that, Mary, and hopefully everyone will have a chance someday to see this satellite. It is a very nice facility. So thanks to Patty Ann and Kelly and team.
I can't keep up, Sharon. We're just rich with celebrations today.
We are.
I do want to be respectful of our panelists and our participants' time in the same vein. So I would encourage everyone, if you can, take a moment and stop and read the celebrations here. But otherwise, I think it's probably best if we call it here so others can go off to work. So Sharon, final word to you. Thanks very much.
Yeah, thank you. And I know we are running short of time. Thanks everyone for joining again. And we do extend a thanks on behalf of the executive team and everyone for all of your ongoing support through this pandemic and all other times. Thanks very much. Enjoy the rest of your day. Thank you.